Good afternoon, ladies and gentlemen, and welcome to the first edition of a very special webinar series on Time to Tame Typhoid, being organized by Unipath Speciality Laboratory and Vanguard Diagnostics. My name is Veena Kohli, and I'm extremely honored and privileged to introduce Dr. Ravi Gaur to you, who's kindly agreed to moderate this session with distinguished medical microbiologists and internal medicine experts from the industry as panelists. Ladies and gentlemen, Dr. Ravi Gaur is the chairman of the Medical Advisory Committee at Unipath Speciality Labs, Ahmedabad, and the founder of DRG Labs. Dr. Ravi Gaur is a renowned oncopathologist and has more than 30 years of rich experience in the fields of pathology, molecular biology, genomics, and immunology. His passion is to channelize the future of diagnostics towards personalized medicine and innovative technologies. So stay tuned as our experts chronicle the history of typhoid and gaze into the future advancements of its early and reliable detection. Over to you, Dr. Gaur.
With me, I have a very distinguished panel. We have Dr. Swati. Welcome, Dr. Swati. Dr. Swati is an internal medicine specialist, more than 20 years of experience in India and abroad. She is actually a social entrepreneur too, and hosts of popular health shows called Dr. Swati's Show on many Indian television channels. In the past, she has been working as the advisor to the chairman of Saket City Hospitals and extensive experience in the healthcare and the wellness industry. She's worked as a consultant in internal medicine with Fortis, Rockland, Max, GB Pant, of course, Indurao, and many more. I think, welcome, Dr. Swati. Your experience is going to be, I think, we all going to benefit and listen from you. That's how we take it forward. Then we have Professor Ashok Ratan, sir. I think. So thank you so much for being on this panel. Dr. Ashok Ratan is the Chairman Medical Committee and Quality Chairman Medical Committee of Radcliffe Laboratory. Then he also was advisor in R&D and Knowledge Forum of that kind. In fact, he is full of knowledge in any case. I'm sure all of you are going to listen as we move forward. He has been a professor at microbiology and of course, from the Mahatma Gandhi Medical College. And he set up many molecular pathology and virology labs. He is the scientific background with a lot of research and R&D work done, and especially abroad in India, in Ranbaxy, SRL, and much more. I think, welcome, sir. We look forward to hear from you as we move forward. Also with me is Dr. Colonel Parthu Roy. I think he's one of the most experienced microbiologists and virologists I've come across, and I think full of knowledge and bubbling knowledge and willing to deliver and make sure that it translates on the ground. He is currently head microbiology and project head microbiology for the Unipath Speciality Laboratory, Ahmedabad, and based in Delhi. He is basically looks after virology, quality virology, operations, quality, and everything what is the microbiologist supposed to be doing, and of course, improving the lab diagnosis. He is otherwise parallel works in the biotech industry. He has worked in Spice Health, especially in the COVID time, and he's been an NMC recognized professional microbiology. His background is like he come from in the past from the Onquist laboratories, and of course the professor, Army College of Medical Sciences based hospital, Delhi, and of course AFMC Pune. Welcome, Partha. I look forward to hear from you as we move forward. Now, before I start, I'd like to just say something about the lab diagnosis methods for typhoid fever has evolved significantly over the centuries, enabling more accurate and rapid detection of the disease. As we embark on the journey through time, tracing the evolution of lab diagnosis of typhoid fever, a disease that has challenged the medical profession over 2 centuries. We look forward to hear the experts and what do they say. I think over 3 series, we will be, we hope to find a good solution and which can be helpful everybody. From the humble beginning, like if you look at the history back of the typhoid, from the humble beginning, you have seen in the video, humble beginning into modern advancements and glimpses into the future. This voyage unveils the progress made in understanding and diagnosing this formidable illness. 200 years ago, diagnosis of typhoid fever relied on the keen observation and clinical acumen of the physicians. Symptoms, we had fever, abdominal pain, GI disturbances, rashes, and much more, often led to a suspicion of typhoid, but definite confirmation was elusive. Lab techniques were nascent, limited to basic microscopy and culture methods. In the late 19th century, the discovery of the causative agent, the Salmonella enterica serotype typhi by Carl Joseph Ebert, laid the foundation for more targeted diagnostic approaches. Microscopic examination tools, samples of bacterial presence became a common practice. That's what the Mary Maron you must have noticed, because she spread through the stool and carried almost 50 people were infected. But the specificity and sensitivity of these methods are modest as of now at best. As the 20th century dawned, improvements and culture techniques enabled the isolation of Salmonella typhi from blood and stool samples. Blood culture in particular emerged as the gold standard, albeit with lengthy incubation period, and that's the biggest challenge today. These advancements marked a significant milestone in typhoid diagnosis, allowing for confirmation and subsequent treatment. But still, I think we have still not been able to satisfy the clinician, because they need, or even customers and patients, who diagnosis is required as early as possible and as efficiently and as precise as possible. Over time, serological tests were introduced to detect specific antibodies against Salmonella typhi. But while these tests are being widely used, they all suffered from limitations, including false positive results and inability to distinguish between a current and the past infection. But I think as we are now moving into the new era, the current century, what we call as, I think, molecular diagnostic era, the shift towards molecular methods, revolutionizing the diagnosis of typhoid fever. PCR has emerged as a powerful tool, enabling the detection of specific genetic material from Salmonella typhi. The PCR assays improved sensitivity, specificity, and the speed of diagnosis, providing a valuable alternative to culture-based techniques. I think probably entire this series we'll be hearing much more about it and the future, how we take it forward. I'm looking forward to the future of typhoid laboratory diagnosis. I think it's very, very exciting, and the prospects are there. And I look forward to have a very, very interesting discussion, and I think a gain of knowledge and for all of us. And thank you so much for all of you being here. Let me start the first question with the discussion. My first question goes to Dr. Swati. Dr. Swati, you are a clinician, you're an internal medical specialist. You must have seen all kinds of patients, and especially the children and even the adults, because that's something, typhoid is really scary, especially the children. Mothers get panicked, rashes happen, the fever prolonged is not going well. So what are the key clinical manifestations and symptoms of typhoid fever? And are there any challenges in distinguishing typhoid fever from other febrile illnesses with similar clinical presentation? I'd like to hear from you, Dr. Swati.
Absolutely. Good afternoon to everybody, to you, Dr. Gaur, all the panelists here, and everybody who's there on the webinar. And thank you so much, Unipath Lab and Vanguard Diagnostics, for having me for this. I think a lot of context has been set up by Dr. Gaur and also the video that we just saw. And as very rightly said, we are talking about a disease which is 50,000 years probably old, and the culprit bacteria may be, speculated that it is as old as the human civilization itself. A disease which has wiped out civilizations, which has, wreaked havoc in a lot of military confinements and a lot of crowded communities, I would say. So allow me to spell out the clinical presentation, the classical clinical presentation, which is mentioned in most of these age-old medical literature that is there. So it says that a combined group of symptoms which establishes the diagnosis of typhoid fever are a gradually increasing fever with evening exacerbation and morning remission, general malaise with headache, a furred tongue with red edges and tip, nosebleed, a relatively slow pulse, possibly dicrotic, abdominal distension with tympany, gurgling and tenderness in the right iliac fossa on firm pressure, a roseolar eruption confined principally to the abdomen and the chest, enlarged spleen, and the physical signs of a bronchial catarrh. Now, should every person who's suffering from typhoid fever comes up with these foregoing symptoms that were just mentioned, then I think the diagnosis would be very simple and the mistakes would not be that common. However, this is not true, and this classical presentation is more of an exception than the rule. So because of this great variability of these presentations that are there, and also the tardiness in appearance of most of these symptoms, a lot of time the diagnosis is not clear, or it gets delayed until a few days passes and a person suffers from the initial symptoms that are there. Also, what we have seen is that the most suggestive features like rose spots and splenomegaly, they take close to 7 to 10 days to appear and might not even appear because the incidence of these is close to 10% to 1.5% respectively. So, a lot of people, they actually don't come up with these suggestive features that are there. Now, coming back to the present decade and in the era of antibiotics, what we know is that with the emergence of more and more resistant strains, especially as typhi, the clinical presentation has changed a lot. Now, what we encountered today are more of non-specific symptoms to begin with. So I would say, generally a person who's suffering from typhoid fever would present with nausea, vomiting, malaise, headache. A person might have myalgias, anorexia, bloating. These are the general initial features. Diarrhea in 66% of the patients, which could be mild to moderate. There could be blood in the diarrhea or not. And then, initially there's a few days of asymptomatic phase sets in, and then the fever because of the bacteremia comes in. And along with the fever, there are a lot of flu-like symptoms initially. So the diagnosis gets very difficult at this stage because generally the symptoms are very vague and there's a lot of overlap with the other general diseases which are there around at that time. Because like if you see, it's generally hits around the monsoon season and we have a lot of other diseases like dengue, chikungunya, and then hepatitis, gastroenteritis, a lot of other diseases which are actually happening at the same time. So a lot of these symptoms, are quite overlapping. And then the fever pattern in typhoid, actually, it's more of a persistent fever, which starts as low-grade fever, and then eventually by fourth day touches 102 to 104 degrees centigrade, so Fahrenheit. So it kind of increases rapidly. Also, what is seen is that what has been, said in the literature, and we have also seen it as clinicians, is a step-ladder pattern of the fever, where the fever, generally rises one day, then subsequent morning it falls, and then it continues as peaks and troughs of an insidious onset, which continues, kind of. There could be arthralgias, there could be bone pain as well, because typhoid leads to osteomyelitis as well. And as the disease progresses, then there are involvement of multi-system over there. And then, there could be pneumonia, a person might come up with cough, or a person might have chest pain because of myocarditis and pericarditis. A person might come up with neck rigidity because of meningitis and intestinal perforate, septicemia, bacteremia, pancreatitis. These are a lot of other complications, that set in with the typhoid patient. And not to miss out the neuropsychiatric manifestations as well. A lot of people come in with delirium, confusion, apathy, insomnia, even encephalopathy and Parkinsonism-like symptoms have been seen with people with typhoid. So it's a very, very wide range of symptoms that we see, especially with the typhoid patients. And so I think if we look at the clinical approach for typhoid from a clinician point of view, I think the history of a person is very, very important, along with his presenting complaints as to if there's a history of, a travel to an endemic area or a seasonal outbreak in the region, or, a history of impure water ingestion or sanitation being poor in the area. So all these things need to be taken into account, along with 3 days of febrile illness, which has most predominantly gastrointestinal symptoms. So since the typhoid bacteria, kind of thrives into the lymphoid follicles of the intestinal gut, especially the pear patches, a lot of time instead of diarrhea, we see constipation as well. So if the GI symptoms are there, especially, bloating, anorexia, diffuse abdominal pain, or diarrhea or constipation, then along with the febrile illness, then I think, we should start thinking about typhoid that is there. Now, if you come to the DD of, the differential diagnosis of typhoid, especially what I would say is typhoid in the literature is said is one kind of a disease which has maximum number of affections. So, since it's a multi-system disorder and we have a lot of symptoms and variability, as I mentioned earlier, it's quite an exhaustive list of differential diagnosis, I would say. And not to miss out, even COVID is now one of the differential diagnoses which is there with typhoid, because a lot of typhoid patients come up with fever and flu-like symptoms. So initially it gets very difficult to differentiate between typhoid and the general viral diseases which are circulating at that time. And the differential diagnosis for TB could even extend up to tuberculosis and abdominal abscesses, if a person is having all those kind of chronic symptoms, or, the disease has progressed to an advanced stage. So the DD gets very, very exhaustive. The important point over here is that not just the clinical symptoms which kind of overlap, the initial lab diagnosis has also a lot of overlap, because neutropenia or raised liver enzymes can be seen with dengue as well, and can be seen with typhoid as well. It can be seen with malaria as well. So a lot of these diseases which are circulating at that times makes the diagnosis even more challenging for that matter. But we have to kind of look for more specific symptoms that are there, or cling on to the history of the patient to make a more proper diagnosis. A very important thing that I would like to highlight here is that during the COVID, what we have seen is that there are a lot of false positive cases of typhoid in people who were suffering from corona, had typhoid positive as well. So we have seen that as well. And it happens with dengue also. When a person is suffering from dengue, we see false positive typhoid cases. Now, one scenario is this, where you see these false positive cases. The other scenario is where you have this co-infection, where people are suffering from two diseases together. So we see a lot of such cases as well, where dengue or typhoid are coexisting. So, we, as a clinician, we need to keep our radars open, our antennas, open all the time.
Let me interpret here. I think there's something rightly what you're doing. There are, of course, the two leading diagnostics people on the panel, and I'm also come from a diagnostic background, not though the microbiology, serology, but the pathology. What I think I'd like to have naturally understanding of what is, as a clinician, so this is a disease which you are now, but what appears to be specific, non-specific, all kind of a symptom, and confused with each and every possible thing I probably feel. I think it's a fever. What is your expectation from as a clinician, from the diagnostic? What do you feel? Are we okay with the current diagnostic? Or what are the things you feel that what we should be giving you? And what do you feel about this expectation, diagnostic people?
Definitely. See, what happens, Dr. Gaur, is that if we look at blood culture, or if we look at Vidal also, these tests are more helpful in the second week of the disease. And, a lot of time, the kind of sampling that is taken and the duration of the disease and all these things kind of, have implications on the test result. So what we need is more of such accurate diagnostic tools which can detect the disease as early as possible, especially in the first week of the disease, and also be more specific and sensitive, because a lot of the tests at present that we have don't have good sensitivity. Even if we come to blood culture, 1 in 4 person might not show the disease. So might not show cultures positive, which means that we are missing out on close to 25 to 30% of the population which might be suffering from typhoid, but we're not able to pick them up. And the problem with typhoid is, most of the studies, they say that early initiation of antimicrobial therapy helps in cutting down the duration of the disease, and also, preventing the complications and the severity. So if we are able to get a clear lead that, yes, this is typhoid, I think it will be much easier for doctors to prescribe these, the treatments, follow those treatment strategies, prescribe the medicines at time, so that, this interplay between injudicious use of antibiotics and the correct use of antibiotics, we could follow the right path. Because right now, doctors are divided whether to, go by your clinical suspicion. Even if you don't have a confirmed case, go by your clinical suspicion and start the antibiotics, or to wait for another 3-4 days, let more symptoms evolve and let more clarity come into the diagnosis of the disease, and then start the antibiotics. So there is a huge dilemma over there, which I think needs to be addressed by the diagnostic aids that you're talking about.
Thank you so much. I think this is where exactly what we are here today. That's why we want to tame the typhoid. I think I'm sure now I move on to Dr. Partha Roy, because you heard our clinical friend, Nishan. I think they're all facing the same dilemma. So I'd like to understand from you, Partha, what are the challenges in diagnosing typhoid fever accurately? And it's not like diagnosis is not on, it's been on since ages, but still the clinical friends are not yet able to, they want something more. And especially in a source limiting settings like in India, where you cannot have the right sequencing at the day one. So what is the challenges of diagnosing typhoid accurately, especially in the resource limited settings? So Dr. Partha, I'd like to hear from you. You're on mute.
Thank you very much, sir, and Dr. Veena also. Thank you for giving me this opportunity. And I think Dr. Swati has put the entire thing into a perfect perspective. And it's really frustrating both for the clinician as well as for the diagnostic industry to actually come up with the correct answer, because there are so many variables onto this. So what I understood, the key word in this entire thing is resource limited. Now, the moment we have something as resource limited, that is where the problem comes up. So I'm sharing a slide. Are you in a? Can you see that slide? Is it visible?
Yes, we can see the slide.
Yes, yes. So when we talk about typhoid in a resource poor setting, one thing I must tell in the very beginning, that to a little bit of good news is that humans are the only host for typhoid, and like other diseases of PUO, we are not really looking at other causes of fever like leptospira or dengue or even scrub typhus, chikungunya, malaria, etc., where there is another intermediate host which we have to deal with. And but having said that, we must tell that the key point here is that is closely associated with gaps in hygiene and sanitation. And second one is that missing typhoid in diagnosis could have very widespread ramification. Now, of course, Dr. Gaur has already said that there have been so many cases, and it looks like after putting a little bit of correction onto the figures, looks like about 6 million cases happen per year in India alone. One very interesting thing is that it is much more in urban areas compared to the rural areas, but the way the second and the third tier cities are coming up, it is again it is spreading to the other parts of the city also. So obviously it is water and foodborne, and if these two can be controlled, probably we may have an answer. Like Dr. Swati has already mentioned, I am reminded of my very early days in clinical medicine, where the doctor would come and say that patient looks toxic. Now, of course, this is a very personal view, but yes, many times you find that especially in case of typhoid, patient did look very toxic. And when the examiner asked that what is the differential diagnosis of a pyrexia of unknown origin, if you did not mention typhoid onto that, maybe he will not pass you. So, as Dr. Gaur has asked, what are the constraints of giving the correct diagnosis at the laboratory level or even at the public level? So firstly, I would say that in a resource poor setting where the people who are affected are generally from a lower strata of society or little underprivileged, or people who are probably working day in and day out to earn their livings, they do have limited access to a physician as well as a diagnostic facility because of lack of time. And in many of the places, the labs may itself lack the necessary infrastructure and equipments. And as Dr. Swati has pointed out, that they are very non-specific symptoms and can be mistaken for other common infections, and this can lead to misdiagnosis and delayed treatment. And many a times, the parents of a child or the patient wait for about 7 to 10 days, thinking that, okay, with a bit of paracetamol or something, it will go off. So a lot of time is lost in that diagnosis. Many people take drugs and medicines. Lack of awareness is at all levels. It's not only with the people, it's also there with the clinical fraternity, with the laboratory staff. So unless this lack of awareness is completely looked into, there will be problem. So they may be leading to this, there may be limited knowledge leading to underreporting, underdiagnosis, and many a times wrong choice of the test. So a person may not be actually asking for, so if there is a fever for about 5 days, 7 days, if somebody may just go in for a dengue test because this happens commonly, or in malaria, and not go for a typhoid. So these are the things that are possibilities that wrong tests are chosen. Now, because there are so many variables available, so many tests, so many times, the reliance is on clinical diagnosis, on the experience of the doctor, and often it is seen that if there is over reliance on clinical diagnosis alone, then it can be a matter which is subjective and can lead to a bit of misdiagnosis. Over-the-counter antibiotics, I have found, is one of the major causes of suppression of the normal routine diagnostic or the clinical spectrum. And this can cause real confusion, because what Dr. Swati said about the stepladder pattern of fever or a bit of relative bradycardia, all this just go off if a person has started taking some kind of a antibiotic on his own. So this is something, and it also will lead to non-identification of the organism, because blood culture may not grow anything because he has already been exposed to antibiotics. That's a major challenge. Antibiotic resistance, fortunately, most of the strains of typhoid, even today, is sensitive to the ceftriaxone, and the older medicine like chloramphenicol are again become sensitive. But yes, antimicrobial resistance is a major problem, in which not only the patient doesn't get well, also the spectrum changes, and there is much larger incidence of a carrier state in those cases. Last but not the least, I would say that cost constraints comes in a big way. Some diagnostic tests can be expensive, molecular characterizations, etc., newer tests like BioFire, etc. So these are not the first line of test that goes in favor of the resource setting, resource poor setting. But then they are very useful. However, because of the cost constraint, that those tests are not prescribed in the early phases, and maybe a lot of cases do get diagnosed much later, but then the affordability is a major concern. And lastly, I would say that being a public health, a public concern, we do have very inadequate surveillance systems. Now, in various countries, people are also talking about probably testing the sewerage. But then in our country, it becomes very difficult. I'm surprised that, Mary Malone, almost in around 1860 or 1870, the people were so careful and people were so knowledgeable that they were able to trace the source of infection. Probably in India, this will never happen even in 2023. But of course, I would end this thing by saying that this has led to a lot of vindictive attitude towards people, which we saw during the plague also, or we have seen during other infections, etc. I think the greatest example of that is one gentleman called Dr. Semmelweis, who was actually anecdotally beaten to death in his lab, in his mental asylum, because he said he was the one who proposed the hand washing for all. So I think that is what I had to say. Thank you, sir.
Thank you, Dr. Partha. I think our clinical friends are saying there is a diagnostic challenge. They're really facing a challenge, and you just told them these are the constraints and the challenges. I mean, these are the various challenges. How do we address that? They want a solution. We also have challenges, but how do we address that? I think then that's where I think we come to Ashok Ratan, sir. So what are, I think my question to you, sir, how do you address this? What are the current diagnostic methods available for typhoid fever? What are the limitations? And what role does serological testing, I think the common test we heard about, serological tests play in the diagnosis of typhoid fever, and what are its limitations again? I think, can you hear from you, sir, for wisdom?
Thank you, sir.
We are not yet able to see your screen, sir. Yeah, we can see your screen, sir.
So the diagnostic test for enteric fever, you need diagnosis, the lab diagnosis to help in, one is diagnosis of acute fever, which will be useful for clinical management. Then you would need lab help to identify chronic fecal carriage, as we saw with Mary Malone. And then when the vaccines are to be tried, then you would like to know what is the burden in the community, so that we could take the right decisions. Now, the diagnostic criteria for typhoid fever, various authorities have used different criteria, and Medscape says the diagnosis of typhoid is primarily clinical. WHO says that it could be both clinical as well as when the fever is there for 38, fever is more than 38 degrees Celsius for at least 3 days, or isolation of the bacteria from blood or bone marrow. And so the overall it is there that the diagnosis could be made either on clinical ground or on microbiological ground. So the the currently available tests, one could be based on culture, but the culture is slow. Then there are immunological, and now molecular tests are available, and some point of care tests are emerging. For any test to be useful, first you have to agree on what is the gold standard, because based on gold standard, you'll be able to then calculate your sensitivity and specificity. And as the report here indicates, that right back in 1975, it was reported in Lancet that bone marrow culture is the gold standard, because there's more bacterial growth in bone marrow than in blood. But bone marrow is painful and it is invasive. So though it is the gold standard, bone marrow is normally not practiced. So serological tests have advantages. One advantage is relatively easy to perform and do not require specialized equipment. They are non-invasive, require only a small amount of blood or serum. They have a short turnaround time. Some results are available in minutes. A few will take a few hours, at the maximum overnight, and they are widely available and can be performed at most clinical labs. And they are relatively cheap, so they are suitable for resource-constrained countries. But they have disadvantages, and the major disadvantages are that they're limited in sensitivity and specificity, so they can give rise to many false positives and false negatives. They can produce variable results, and it depends upon the population that is being tested on and what test has been used. So you cannot extrapolate from one society to another society or one country to another country. And they cannot differentiate between current and past infections most of the time, and they cannot identify Salmonella typhi in asymptomatic carriers. With these limitations, there are at least 11 different serological tests which have been described and used. Vidal test has been there for more than 100 years, and I'll come to, these all serological tests are based on Kaufman and White serological scheme, which is based on 46 somatic antigens, 86 flagellar antigens, and these flagellar antigens occur in two phases, phase 1 and phase 2, and there's one VI antigen. Why somatic should be known as O and flagellar should be known as H used to be a confusion to me till I came across a person who knew some German, and he suggested that it is because Kaufman and White were from Germany. Kaufman was from Germany, and when you have flagella, then the bacteria grows as a mist. that means houch. Houch means mist. And that's why if a flagella is present, then it is H antigens. And when the bacteria loses the flagella, then it becomes only houch. That means there's no cloud. So that's the O antigen. So somatic antigen, which is actually lipopolysaccharide, which is the outer layer of the bacteria, and there are 46 O antigens. Normally, when we isolate the bacteria, we use antisera, which has been heavily adsorbed, so that cross-reacting antigens are removed. But as you see here, Salmonella typhi, the lipopolysaccharide is designated as 9, and the flagellar antigen is designated as D, and it has VI antigen. And these antigens are shared, so that infection by others will also lead to antibodies to this. Same is the case with paratyphi A, B, and C. A review published in 2000 by Latif and King in postgraduate medical journal of 100 years of Vidal test indicated that the definitive diagnosis always depends upon culture. But Vidal test had a role in increasing the suspicion that it may be infection. And in developed countries, it has been actually abandoned. Nobody does Vidal tests in developed countries. There they rely upon culture. But unfortunately, in developing countries and resource-constrained countries, they still depend upon Vidal test. Vidal test can be then initially described was using tubes. The tubes would have different, the serum is diluted as a twofold dilution, doubling dilution, and equal amount of killed antigens are added. And after overnight incubation in an incubator, it is whether there's agglutination or not is viewed using a concave microscope so that it magnifies a bit. And if there's agglutination, there's clump formation, that would mean that agglutination is present, and then we can also look at the titer. Since this would take overnight incubation at least, this was found to be too slow, and so slide agglutination using 1 drop of the antigen and 1 drop of plasma or serum was then used. There's been one paper that I could find from Lucknow where Noorjahan has compared slide agglutination with tube agglutination. And the trouble with this paper was that they're using Vidal test as the gold standard. And anyway, she found that slide agglutination, though rapid, would give many false positive tests. For using Vidal test for diagnosis, you need to know that since this is a cross-reacting antigens are present, that would mean that even healthy persons would have some baseline titer. So many scientists normally in their own environment test samples which have come from blood bank indicating healthy individuals, and then they published about what is the normal titer which is available, so that should be taken as normal. And if the titer is above that cutoff, then you can consider that Vidal is positive, and it might have a significant role provided a person is symptomatic. Normally, it's taken that 1:160, that means 160 times the plasma or serum can be diluted and still you get agglutination, then you should consider that might be positive. The agglutination is possible because of the presence of IgM antibodies, which are current, as well as IgG antibodies, which can persist for long. Since IgM antibodies last for about 3 months or so, we normally consider that agglutination which occurs. Ideally, for serological test, you should have 2 samples, at least 10 days apart. But that, of course, is not possible in clinical situations. So you have to decide on the basis of 1 sample and whatever is the titer available. Since we were looking for IgM antibodies, immediately after I passed my MD and I was made in charge of serology, in the fridge, I found 2-mercaptoethanol. 2-mercaptoethanol destroys IgM. It destroys the SS bonding of IgM. So I reasoned that if you do Vidal test in normal saline, and then you do Vidal test again, now with normal saline containing 2-mercaptoethanol, instead of rise in titer, if IgM is destroyed, then 2-mercaptoethanol will show you fall of titer. And if the titer fall is more than two tubes, that would mean that the Vidal test positivity that you were getting is actually because of IgM, which means current infection. If there is no fall, that would mean that it's all IgG, and that would mean that it's not a current infection. So I noticed that a few other colleagues have also tried the same, but it gives a lot. We used to do this just before lunch because 2-mercaptoethanol gives a very bad smell in the lab. So you need to incubate it and then go home rather than be in the lab. But this is one trick that we tried. Now, of course, mention has been made of Typhoid.IgM. Typhoid.IgM depends upon detection of IgM antibodies against outer membrane protein. And this came out of Malaysia. And they have noticed in India, it's been reported in Mysore with good sensitivity and specificity, and also from Patna. And they have reported that it gives better, Typhoid gives you better results, faster results than even slide Vidal test. There's also a test known as TUPEX, which comes out of Scandinavian countries. Here, there is magnetic beads, which are then allowed to bind to different color. And if antibodies are there, that these beads are coated with lipopolysaccharide of Salmonella typhi. And if antibodies can bind that, then the color change will be there. After 10 minutes, you can look at the color change. And then there is a card available where you look at the score. And if it is violet, it would mean that it's positive. If it is red, it means it's negative. So in 10 minutes time, you can know whether it's positive or not. All the 10 or 11 tests that are available, there are various manufacturers, and they look for both IgG or IgM. Its normal agreement is there that IgM would indicate present infection, but the trouble is about the cross-reactivity, and that's why though tests are available, it was the sensitivity and specificity is normally less than ideal. And so there could be many false positives and many false negatives with each of these tests. There's also a test which looks at antigen detection either in the blood or stool. And this has also been tried, that instead of culturing the bacteria, and antibodies will be response, but if you want a rapid diagnosis, then an antigen may be available. But again, whether you're detecting the specific antigen of Salmonella or it's a cross-reacting antigen, that will always be a problem. So those are the tests which are available, which can be used. What the serology doesn't do is tell you the sensitivity of, it can make a diagnosis along with your clinical acumen, but it cannot tell you about drug sensitivity. And as you notice that in our neighboring country, there is XDR, there's an outbreak of XDR typhoid all over the country. and people visiting from China had taken the bacteria to Beijing and caused an outbreak there. So serology may be useful in resource-constrained countries, but it cannot replace the property of culturing the bacteria and then determining the antibiotic sensitivity, which is essential.
Thank you so much, sir. I think you've really given us a good insight of what's really happening inside our labs. And I think it's not like we are not concerned. I think diagnosticians are actually working very hard. And I really listened to know what you talked about. You found something in the refrigerator. And that's very nice. I think I really don't know, because this is something you talked about to mercaptophenol. Only smell is the something which keeps us away, or there's something else probably. I think all of us probably, or wherever the clinicians feel that there's strong suspicion of the typhoid, but still Vidal is not giving the right picture, maybe we can still try that test. And there's a very simple test which appears to be, except you have to put a double mask on your face, nothing more than that. Thank you so much, sir. Great. I think we'll come back to you. And my question, you raised a very important question of the drug sensitivity, because this doesn't give a drug sensitivity. So I think today is an era of antimicrobial resistance, and how do you give preemptive kind of antibiotics? So before I ask this question to clinician, actually, because I like to just tell you, there are certain questions in the Q&A and the chat box. Any of you probably are willing, you can please answer there. So Dr. Swati, my question to you is, we just talked about, there's no test which actually gives today, as of now, the drug sensitivity when it comes to Vidal, probably except you talk about the blood culture, or maybe whatever it is. But Vidal-wise, how does the emergence of this AMR resistant strains, because you must have seen the resistant strains coming up because of the AMR, and has affected the clinical management typhoid? Has it affected? Has it not affected? And how is it affecting? And what would the future? Dr. Swati feel?
Absolutely, Dr. Gaur. I feel, as more and more AMR is emerging, the task of a physician gets more and more uphill, because, there are a lot of what we have seen with AMR is, one, the treatment gets very difficult. There's a high incidence of treatment failure that we see. The relapse cases, they kind of go up. Also, what we see is the spread of the disease increases. There are more chances of complications, severe death, and not just the clinical course of a person, even the cost of treatment for that purpose, it gets very prohibitive, because once a person has AMR, or the strains are resistant to the general antibiotics that are around, what has been seen is that such patients, they require more of inpatient nursing care. So their cost of treatment automatically goes up. So I think what is more important here is to understand that we need to have such diagnostic tests, though Dr. Ashok Ratan sir has clearly outlined as to what are the limitations at present, but we definitely need to have more innovative path-breaking tests which can help us identify these typhoid cases earlier. Because as I said before as well, the problem with the clinician is the study says that we should start antibiotic early if we want to, want to cut down the complications, the severity of the disease. We want to shorten the disease, but at the same time, the large surveillance at the clinical suspicion of a disease without a confirmed bacteriological diagnosis, there is, when we look at these cases, only 1 to 4% of the cases actually qualify as bacteriologically confirmed cases. So there is a high chance and there is a high incidence of doctors prescribing antibiotics which are actually not required as well. So we are, it's a catch-22 situation where, one, we need to start the antibiotics early, and second, we are using, we are indiscriminately using the antibiotics as well. So we have to be very, very cautious when we use these antibiotics. Also, if you look at the history of MDR strains in typhoid, what has been seen is that, first strains came up in 1970s, which were MDR strains, and then fluoroquinolones resistant strain came up. And as Sir just rightly mentioned, in 2016, the XDR, which are extremely resistant strains, which are resistant to all the antibiotics that are available there, except azithromycin, have also surfaced. And to our surprise, or not to our surprise, I would say, because of the use of too much of antibiotics, now we have seen cases which are resistant to azithromycin and third generation cephalosporins as well. So what we are dealing with, we actually don't know when we are, as clinicians, when we are giving antibiotics and all, we are not very sure whether the person is, resistant to certain antibiotics which are there in our armamentarium. Also, very important point that is here, which has been shown by the field surveillance, is that, these typhoid conjugate vaccines, which are very, very effective in XDR cases, which are close to 80 to 95% effective in such cases, when they were administered in Pakistan in a very large scale, what they found was the cases or the incidence of the disease was not going down. So they were very surprised that the vaccine is so effective, it is 80 to 95% effective, yet the cases are not going down. So they started looking for more reasons as to where is the problem, why the vaccine, despite such good efficacy, is not working. And what they found out is, again, leads us to diagnostic aids. What they saw was that since the vaccine is not too, it's less available, the vaccine is costly and can't be given to each and every person, what happens is that they need to isolate these hotspots where these infections are very, very rampant. And isolation or identification of these hotspots is only possible if we have good diagnostic aids, which can actually kind of detect these hotspots where the infection is too rampant, and then a judicious use of vaccines at this particular place can actually kill the disease or curb the disease for that matter and bring down the incidence. So I think looking at a clinical picture and also from the point of view of vaccines, which are very effective, again, it comes down to the same point that there is a lot of urgency to have such diagnostic aids, which, kind of detect this disease quite early with a lot of sensitivity and specificity so that the antibiotics can be started early. Now, what happens is, as a clinician, when we are sitting in this monsoon season, we have the viral diseases and we have these bacterial diseases. And the doctor is in a dilemma whether to start antibiotics or to wait for another 3-4 days for the disease to unfold, considering it might be a viral disease and we are without the need, we are giving these antibiotics. So if we have such tests which can detect them, I think it would be much easier to target even. And a very important point that I would like to make here is what these studies have shown is that if we are able to develop precise treatment strategies for these strains which are resistant to typhoid, then we might see reappearance of strains which are susceptible to antibiotics which we were using earlier. So we might see strains which are susceptible to fluoroquinolones or chloramphenicol, which might be a big breakthrough and help us not, look for more antibiotics which are beyond third generation, fourth generation, fifth generation, because we know such antibiotics have a lot of other harmful effects as well. So, going forward, if we could go backwards and go back to our old antibiotics, that would be a much easier and cost, saving effort if, we kind of find those diagnostic aids.
I think rightly said. I think you are facing a big challenge of resistant strains and AMR. I think we probably we are also on the other side looking for a solution. And I'm sure with that, because, when it comes to what do you require is a rapid diagnosis, you require a fast diagnosis, a timely diagnosis, an accurate diagnosis, and probably which could be identifying hotspots. So probably a role here is of rapid diagnostic tests. Although Dr. Ashok had mentioned a couple of them, I'd like to ask this question to Dr. Partha. How can rapid diagnostic tests for typhoid fever be effectively implemented? I'm talking about when talk about India, is a low resource setting where access to healthcare infrastructure is still limited. And are there any significant new advancements in diagnostic technology that improve the accuracy and speed of diagnosis? Dr. Partha, please.
Yes, thank you, sir. So again, I think this question is in two parts. One is we require something rapid, effective, and cost-effective also. The second part is that the newer diagnostic tests, the research, and how these are going to change the patient care. But before I start, I would just like to mention about the few biomarkers that can kind of help in differentiating between whether it's a bacterial infection, viral infection, or a fungal infection. So what has been found is that a pure bacterial infection can be probably identified fairly accurately using a procalcitonin test. Although the CRP that is used is little less specific, but PCT is fairly specific for bacterial infection. Whereas when it comes to, say, fungal infections, nowadays bloodstream infections by fungus are quite common. So if it is an aspergillus organism, then galactomannan helps as a biomarker, or otherwise any other fungal infection. There is a universal biomarker called 1,3-beta-D-glucan, also called the fungital assay. As far as viruses are concerned, one biomarker has come up in the research that is called IP10. So if biomarkers are used consecutively or in combination, maybe one will be able to identify a bacterial, viral, or a fungal infection. But again, the question of affordability and availability comes into play. Now, having said that, since we are again come back to the cost-effective part of it and rapidity, I would say that a lot of work has already been done in the last 200 years, and tests now are available. We are aware of the efficacy of those tests. They are affordable. Also, we know that what are their pitfalls. So we are aware of them. So I think in the present scenario, we have to rely on these tests because in a resource poor setting, these are available and they are cheaper. But the right test must be used at the right time, and that is the mandate of the typhoid infections per se. And at the very beginning, I would say that before going to the specific test for the typhoid, we must not neglect the routine test like a CBC or a peripheral blood smear. A peripheral blood smear shows up things like toxic granules, shows us relative neutropenia, and shows up a large number of things, which is, in addition to the clinical suspicion, also helps in going more towards typhoid. Even if there is a lymphocytosis, one might get an idea whether, yes, this could be probably a viral infection and or presence of virocytes. These are all very normal activities of a peripheral blood smear by any trained pathologist. Now, going to various other microbiological or other tests, I would say that in case there is a fever, there's a high suspicion in the first week, I would still say that one should go for the blood culture. Now, in our resource poor setting, blood cultures can be of two types. One is what is done by the automated BACTEC system, which is expensive. The other one is the old conventional system where we used to use the routine BHI. Routine BHI, in case of salmonella, will grow it if the amount of blood collected is correct and properly incubated. Now, the question is, these are much, much cheaper. Nowadays, blood culture bottles of BHI, etc., are available at less than 50 rupees a bottle, and one can even do a paired sample on that or take two samples. Compared to that, the BACTEC, BITEC are slightly expensive, but the quality has to be maintained very well. Now, my question is that how can the blood culture may be made rapid? In my tenure in the armed forces, I had made it a particular system where whenever the blood used to be collected, I used to do a blind subculture after 6 hours. And in many cases, especially in case of salmonella, if the sample has come to me around 10 o'clock in the morning, and when I'm leaving at about 4 o'clock, I was able to do a subculture many a times. I was able to get an organism isolated by the morning 6:30, 7:30, because these hospitals are 24 hours manned. So that is one part of it. Secondly, even in the first week or 7th or 8th day, a typhidot helps. Typhidot is a very simple test. As I said, yes, there may be certain cases of false negative, but if it is a positive, and the clinical suspicion is high, supported by a proper CBC as well as a good PBS, I think the diagnosis is clinched. But in another 15-20 hours, the culture reports will also come, and they are usually positive in the first week. Now the question is that, yes, if it goes to the second or third week, when the culture positivity goes down, this is the time where, of course, the serology comes into play. And again, in the second week, a typhoid will become positive. A Vidal usually becomes positive at this particular point in time. However, because a resource poor setting, we are probably not very well in a position to probably apply a PCR at this point in time, and which may not be available in a second or third tacity, but that will be a good idea. However, by the third or fourth week, both Vidal and the blood culture will become probably negative, and the patient may be a carrier. At this stage, how do we do? Yes, there are tests like the VI antibodies. VI antibodies remain positive in cases of carriers, and here the stool culture makes a very important inroad. Now, stool culture is a very, very sophisticated and a little thankless job also, because there are too many media available, Wilson and Blair media and GN media and all, selenite broth and all. Here, the experience of a microbiologist and team comes into play. Otherwise, we are going to miss this. So in the third, fourth, stool culture is very important. Now, coming back to the second part of Dr. Gaur's question, that if you want speed as well as accuracy. Now, when it comes to accuracy and speed, culture although remains the most important gold standard, but there are something called a culture PCR assay. Now, you can do a PCR at the very beginning of a highly suspected case where it will come out to be positive. However, in certain cases, the PCR may not be able to pick up a actual true positive, because the level of detection may be lower, or at that point in time, the patient may not have that many because it may be transient. However, if this culture bottle is incubated for 3 to 4 hours, and by that time the bacteria goes into a log phase of growth, that is the time if a PCR is done, most of the time this will come positive. So it is a blood culture, you have got a PCR positivity also in this particular case. However, how do we diagnose polymicrobial infections? Usually bloodstream infections are usually monomicrobial, but polymicrobial infections can occur if the patient is highly immunocompromised, or is a renal transplant case, or on steroids, or uncontrolled diabetes. There are a number of them. In these cases, probably newer techniques that are there, for example, things like, say, BioFire or QIAGEN, QuantiDx, etc. These hybrid models, I think, can really help, where within a period of maybe 2 hours, you not only get the identification of the organism, you also get some antibiotic markers, even markers like MEG gene, etc., or NDMs, etc., so that you know what it can be resistant to. However, a phenotypic identification will always be important in these cases. What I want to say is that if we want to have rapidity and accuracy, probably we'll have to have a panel of tests, maybe in the hospital, considering the affordability part. So we have to have the routine test, we have to have the culture test, we have to have the molecular test, and also we have to have biomarkers. It is up to the patient, up to the clinician, that what he or she is comfortable with, and what knowledge a person has regarding those tests, and can come to a conclusion that what exactly needs to be done. Thank you very much.
Thank you, Dr. Pather. It's very, very nice insight. And I'll just say that there are a lot of questions are there in the Q&A box. Please have a look. And meanwhile, we hear from Dr. Ashok Ratan. I think you can answer those questions. A lot of audience was just showing they have a lot of questions in their mind. So I think Partho mentioned about the new technologies and what could be done, and probably talking about blood subculture and all things, because that's something right from basic CBC to high-end molecular kind of testing. I'd like to understand you from Sir, Dr. Ashok Ratan, sir. What strategies can be employed to improve? Now, what is the strategy should be the early detection and prompt, because that can lead to the prompt treatment of typhoid fever, considering how complicated it is, how non-specific it sometimes becomes, and it's a big challenge, and relapses are pretty common. A patient can even become an asymptomatic carrier. What should be the strategies? And I think you being a scientific background, you've been a scientist for a long time also. So like a quick, because we don't have running short of time, but I can have a quick review. What are the ongoing research efforts? And probably we should be now focusing on as we move forward. So please.
So let me just share my screen.
Yes, so we can see that, sir. Also, meanwhile, please answer the question out there. I'll also try.
As it, I think it's best to have blood culture, which is automated, because that will give us the results very fast. And I can share the results that we got with Salmonella in the last 2 years. And lo and behold, most of the Salmonella that we have isolated in 2019 and 2020 are sensitive to everything. So though our neighboring country has XDR, must share their sensitivity pattern with their clinicians at regular interval, so that the clinician knows what is the prevalence of resistance occurring. Though, of course, in our chat box, I've been noticing that of recently, resistance in Salmonella typhi has been reported. But if you want a rapid test, which can be done on the same day, I think PCR is what is essential. And PCR could be a regular PCR or a nested PCR or real-time PCR, which is also known as qPCR. Then it could be multiplex, as Dr. Partha mentioned, or as culture PCR, which the sensitivity increases. And there are various targets. This I'm sharing as a nested PCR, which Dr. Gopalnath in BHU had done. And he found that if you depend only on blood culture, then maybe only 17 would be positive. But if you have nested PCR will have 53 out of 57 positive. And the PCR itself will take about 3 hours. So it is the same day report. That would mean that if a person has had fever for 3 days and you give the sample, because that's the amount of time normally it takes before a person decides to go in for an investigation. And then on the first day itself, we can give a positive results, while culture would take 5 to 6 days. So PCR would give you results. It's noticed that PCR for typhoid is not very sensitive. It needs at least 30 CFU per ml for it to be detected positive. While in normal situation, the bacterial load of typhoid bacteria is less. It's more in bone marrow. That's why bone marrow culture is positive, while blood, it is slightly less. So one could be that you take more amount for blood culture, or heparinized blood could be then inoculated straight away into 3% ox bile in tryptone soya broth. And after 5 hours, as Dr. Partha said, it could be centrifuged. The deposit could be used for extracting the DNA, and then PCR is done. The sensitivity will increase many-fold if culture followed by PCR is done on the same day. So we don't wait for 5 days for culture to be positive, but we amplify 2 or 3 cycles so that now the bacterial load has become enough. And what is emerging also is loop-mediated isothermal amplification. The advantage of this is that there are multiple primers which are added. And so the amplification is such and so rapid that it can be read by naked eye. And I would think that once loop-mediated amplification has been adapted for Salmonella, then it should be possible for many labs to do this on the first day itself. And if it is combined with first ox bile culture, and then after 5 hours, then with lamp, then on the same day in 20 minutes time or so after it's been started, results will be available. But at this moment, PCR would be the system that a real-time PCR, where the results are available on the same day, would be one option of getting definitive diagnosis quickly.
Okay, sir, I think that's very nicely said, because I think there are one of the very important question they have raised somewhere in the chat box. Is a false positive more dangerous or false negative more dangerous? And especially the era of AMR. I'd like to hear from you answer on that, because most things are present actually in the Vidal serology testing. So your views, sir, a little bit of, can you throw some light on that?
So both are dangerous, because ultimately in India, as I said, the first report of Salmonella typhi being resistance was by Panikkar in 1972, which he published in Nature. And in 1990, when we started doing more work on Salmonella, we found that the bacteria is still sensitive to everything. So there is a cost that Salmonella typhi has to pay for being resistant, and that leads to decrease in its multiplication. So it tries to get rid of the resistant genes whenever possible. That whenever is possible, if we do not misuse the antibiotics, if we do not unnecessarily prescribe the antibiotics, then that pressure, selective pressure, would be gone, and Salmonella typhi will again become sensitive to. So at this moment, what we are noticing is majority, even in the worst condition, 60% were resistant, 40% were still sensitive to everything. So we should not presume that just because everything else is becoming AMR, Salmonella typhi is also becoming resistant. But yes, there is a threat that XDRs are available, and it can cause outbreaks. So we should protect ourselves by taking conjugate vaccination. All of us should take conjugate vaccination. And of course, now that there are so many toilets available, and since there's no extra human source, so if the stool is disposed of correctly and the water is pure, of course, I know what's happened in the recent past after the floods. If the water is boiled and then drank, then hopefully we would break the chain of typhoid. In the meantime, we can do PCR for rapid and definitive diagnosis.
Thank you so much, sir. I think sanitation and hygiene is the answer, definitely, for anything. And I'm sure all of us have been saying this for a long time, but it's not an easy job. It's a highly challenging thing. But I think if we take little care, we can take care of a lot of things in this. I think we have multiple questions out there in the box, and I think a couple of them will be answered. One more question right here is for PCR, you already mentioned about the blood, the culture, the growth, which is probably the PCR is the best method. What are the other samples we can use for PCR? So can you, any just quick 30 seconds?
No, we haven't tried it, but I would normally, when they used to say that the bacteria could be found in the blood. For, of course, Salmonella typhi would be in the blood, but then Topley Wilson used to say BASU, blood in the first week, agglutination second week, third week is stool, fourth week is urine. And normally what would happen is, since it has a tendency to become carrier, so stool will be positive for longer period. And that could be of public health importance. So either if PCR has to be done, then blood is the first one, but maybe urine also could be tried and stool could be tried.
Thank you so much, sir. I think we have a lot more. I think this is the 3 webinar series. Probably the second one you'll talk about more as the advancements happened, and third one, your important point of the vaccine, the public health challenge. I address and tell my audience, whosoever are there, please keep logging in on the next one, which is I think we will get back 10th of August and followed by some in September. We will definitely hear whatever the answers are and probably will arrive at some conclusion. So I think I like to summarize kind of a thing here. in the recent years, advanced molecular technologies, a lot of serology, a lot of blood culture, conventional thing, and a lot of advancement has happened. And a lot of, I think I can reassure you from the diagnostic side, a lot of still our pathologists and microbiologists and virologists are working together. So anywhere you're a challenge you face, probably the clinicians also, please come back to us. We are not it's very difficult sometimes to convince them the first sample and then again a second sample to be paired sida kind of a thing. They find it a little difficult because they feel that something treatment should be given today. But I think the clinical interaction is very, very important when you have such suspicion and such reports. And I'm sure Swati will be agreeing with that. How do we, because that's more important to talk to each other whenever you have high suspicion, but still the results are not in line with the clinical diagnosis. So in recent years, however, we have a lot of advancements with molecular techniques like whole genome sequencing, the NGS, but they're all expensive. But I think with time, this will going to evolve. I think you hear more about in the next session. These techniques will allow genetic material for the various strains, and especially heading the outbreak investigations, what we really see probably in COVID in the recent time. Then AMR profiling and understanding the disease epidemiology, identify the hotspot and contain that kind of area so that at Mary's spread to 50 people, probably the spread will be limited. Looking ahead, the future of typhoid, it holds exciting, prospects to my mind. Rapid diagnostics is leveraging innovative technologies may become more accessible, offering quicker results. Biosensors, nanotechnology, AI may pave the way, and I'm sure you're going to hear this thing more in the next session. Furthermore, ongoing research in vaccine, and Dr. You mentioned about it, Professor Ashok Ratan, develop more effective vaccination strategies and what should be and what point of time, who all should get it. And I think that's also a very, very important measure. As we reflect on this journey, we witness the relentless pursuit of improved diagnostic tools. We assure you that something is always on. We are trying to empower the healthcare providers in the battle against typhoid fever. We are there with you. From the early days of observation to the modern era of molecular diagnosis, progress has been made, but challenges still remain. I think together we can definitely conquer that. So let us embark on the future with unwavering curiosity and determination. Together, through continued research, innovation, and collaboration, we can unravel the remaining mysteries of typhoid fever and forge a path towards its eradication. With this, I think I'd like to thank all my panelists, Dr. Professor Ashok Ratan sir, Dr. Swati, Dr. Parth Roy, and we have Veena Koleji, Vanguard, and Unipath Specialties. I think all of us who were behind the team to make it a great webinar session, education academic series, which is continue. The next session going to be on 10th of August, where we're talking about advancement on diagnostics. And I'd like to close with two lines, unless anybody wants to say 30 seconds something, sir. Otherwise, I'd like to just put a small quote.
I just wanted to add that we have recently introduced PCR, and we are offering it at 3 options. One is PCR alone. PCR, if the fever is for less than 1 week, then PCR and culture. And if it is for more than 2 weeks, then PCR with Vidal test. So 3 options we are offering.
Thank you so much. I think that's something that in the molecular era is already arrived. And I think we'll hear more about it. I think people now answers got to be resolved. I'm very, very sure. Molecular more generally is more precise, but I think the sample type matters are more important there. I think we'll look into it as we move forward. With this, I like to just put my closing note here, which says that disease-free health is a relentless quest. To tame the typhoid still remains a daunting test. A fire burns to reach the goal, to conquer this strife and have a healthy typhoid-free life. So let us walk together, united strong. In the face of challenge, we will march along. With science as our guiding light, we will rise above the formidable fight. Though time may pass, our spirits won't wane. Together we'll seek, together we'll gain. The day will come, the typhoid reign will cease, and we all shall live in the healthful peace. Thank you so much, everybody, and thank you all the speakers, and thank you, Vanguard, Unipath. I hand over back to Veena Koleji and for the thing, and thank you so much. Veena ji, please.
Thank you so much, Dr. Gaur, Dr. Ratan, Dr. Swati, Dr. Partha, for such an informative, insightful, and engaging session. It was all encompassing, covering the clinical and diagnostic spectra at the same time. And thank you to all the attendees who stuck with us throughout the session in good numbers. And I request you all to tune in on the 10th of August again, same day, Thursday, same time, 3 to 4 p.m. on advancements in typhoid detection. And last but not not the least, I want to say to Dr. Ratan, my senior at Ranbaxy and the All India Institute of Medical Sciences, that your acronym for BASU is going to stay with many of us after this session. Thank you very much and have a good evening, everyone. Thank you so much once again.
Thank you, everybody. Thank you.